So tonight we're talking about antivirals, antifungals, and antiparasitic drugs or antihelminthic drugs. So as always, we're going to start with our learning objectives. So we're going to talk about effective medications in the treatment of fungi, viruses, retroviruses, and parasites. We are not going to talk about mycobacterium this evening. We're not going to talk about tuberculosis. We're going to talk about the classification drugs for fungals, or fungal infections. We're going to talk about common viral infections and what medications and supportive therapies are used to treat them. We're going to talk about different classes of medications used to treat the different viral infections. We're going to talk specifically about HIV and the different classes of drugs used to treat HIV. And then we'll talk more, kind of think through how we can relate that back to the nursing process. Of course, we've got our old friend, the NOF wheel. So as you're thinking through things that might be related to this patient, how would we use informatics and technology to develop new drugs or to administer drugs or to track if a patient is able to take their drugs? How would we look at evidence-based practice as medication administration is changing? So trying to think through what parts of the NOF wheel are involved in the different types of care for patients. Of course, we've got our ATI clinical judgment wheel. So thinking about what would tip you off that a patient is developing a viral infection? What would tip you off? What cues would you be analyzing or recognizing that a patient has a parasite? And then how do we go about making sure that the medication we're giving them for an infection is being effective? So first we're going to talk about fungi, protozoa, and helminth. So what are they and how do we treat them? So fungi are they're living beings and they are decomposers or recyclers. So they need some sort of host in order to break down parts of that host and continue to survive. So they're often slow growing. They are multicellular organisms. And we're going to talk about those first when we get to the bulk of our presentation. Protozoa are single cell organisms. They're often found in soil and water, and then they get transferred from those into our animal and human hosts. And so fungi are going to require treatment for multicellular, while protozoa are single cell organisms. And then helminth is just a fancy word for a parasitic worm. So we're going to be talking about worms, how they're transmitted into the body, and then how do we treat them once a patient is infected with a helminth or a parasite. So we're going to start with fungi. I tried to include some of my favorite fungi. So you'll see mushrooms, yeast are those little black ones up in the corner, and then we've got my absolute favorite, which is cheese. So the way we make blue cheese or gorgonzola is to actually inject it with a fungus. So fungi really only have three ways or three portals of entry into human hosts. So either a human will touch an overgrowth of fungi in the soil. So think about if you're walking through the woods or you're planting in a garden, or we're touching an overgrowth maybe in a shower, and that's how we end up with athlete's foot. Those are all ways that we're getting in contact with a fungus. We can inhale a fungus. So spores might exist in the air. This often happens with molds in the bathroom. If a patient doesn't have a well-ventilated shower and mold is growing between the shower and the wall, the patient can actually experience symptoms by having inhalation. And then that fungus will proliferate inside the patient's lungs. And we all have fungi who live on our skin. And so we can unfortunately have a situation where a patient has overgrowth of normal fungus. So we may have a patient who has yeast that lives on their skin, and then something in their chemistry changes. Perhaps they're taking a medication, perhaps they've developed diabetes and they have more glucose available, and that leads to overgrowth of a natural fungus or yeast that lives on the skin. It's uncommon for fungi to be transmissible between hosts. So for example, it would be very hard to pass a fungus along from person to person with the exception of athlete's foot. And so one of the most susceptible populations for fungal transmission are actually our immunocompromised patients. So patients that we're going to talk about tonight, like HIV patients, can be very susceptible to fungal infections. Patients who are receiving chemotherapy or anti-neoplastic agents, who have an immune system that's becoming compromised because of cancer care. Patients who use long-term corticosteroids. Patients who have extensive burns. Patients who are in the ICU who may or may not have indwelling vascular catheters. So patients with a PICC line, if you're familiar with PICC lines, or central venous access device in their neck, may have more susceptibility to fungal infections. Patients who've received an organ transplant because they're on immunosuppressive medications, and patients who have severe illness that's already contributing to an immune system fight. There are different fungi that infect healthy people versus our immunocompromised patients. So it's going to be really important to get a very extensive and thorough past medical history if you suspect your patient has a fungal infection. So there's two types of fungal infections. So there are systemic, so those that impact the brain, the lungs, and the digestive tract. Those will definitely require PO or IV medication. Whereas our superficial fungal infections will be on the skin, it might be in the nails or mucous membranes, and those we usually can use either a topical medication that's either a lotion or a cream. If it's oral mucous membranes, we might do a swish and spit or a swish and swallow if we're talking about a yeast overgrowth, candidiasis overgrowth in the patient's mouth. And so when we're talking about treatments, we're going to be talking about the ergosterol wall. It's the part of the cell membrane that's specific to fungal cells. And so when we talk about azoles, that's one of the medications, and amphotericin B, they're actually going to inhibit the formation of that cell membrane from ergosterol. And it's going to cause the plasma membranes to be leaky and allow the cells to die. So talking about our superficial fungal treatments. So these are things like vaginal yeast infections or oral candidiasis, so an oral yeast infection, athlete's foot or jock itch. So our common therapies are going to be clotrimazole, fluconazole, and nystatin. And so of those three medications, nystatin is going to be our prototype drug. And so it acts on the fungal cell membranes. Again, it's going to inhibit the formation of that lipid layer. Nystatin can be given PO. It can be given as a cream or an ointment. It can be used as a powder. It can be given as a lozenge. Again, if the patient has an oral candidiasis infection, swish and spit, coating the entire oral cavity with nystatin, or swish and swallow if there's concern that the candidiasis is now traveling down the patient's esophagus. And we want to make sure that we're getting that nystatin all the way down. And so the really important part is knowing what route is the most effective route and whether or not the patient is able to have the mouth coordination to swish and spit, particularly if we don't want them then swallowing, depending on where the infection is. The most common adverse reactions, especially for the PO, is going to be nausea, vomiting, diarrhea. There are a few interactions to be aware of. So warfarin and digoxin, so some of our cardiac and anticoagulant medications, other antibiotics and vancomycin, steroids and muscle relaxants, as well as anti-diabetic medications. And so just being very aware of what's going on with your patient to avoid those interactions. When we're talking about systemic antifungals, we're going to be talking about amphotericin B and the azoles. So IV amphotericin is going to be administered slowly over 2 to 4 hours. After a 1 milligram dose is going to be administered IV push slowly. There's a very large risk for hypersensitivity. And so we would want to make sure that we have our antihistamine medication. So we had talked about IV diphenhydramine. So we would want to make sure that that patient receives that if there is a risk of hypersensitivity prior to the administration of amphotericin. And you're going to monitor vital signs and the patient's overall status for the first 15 minutes of the first dose, because that's most likely when the patient's going to have specific allergic reactions or things like nausea, fever. It can cause ototoxicity. Remember, we talked about ototoxicity when you were learning about vancomycin, and it can cause cardiac dysrhythmias, which is why we really want to be very careful within those first 15 minutes. And we want to give our test 1 milligram dose slowly. The interactions are actually going to be the same as our superficial antifungals. Next, we've got our azole antifungals. So we're going to talk about ketoconazole and fluconazole, which is both superficial and systemic. And so for fluconazole and ketoconazole, again, those are all going to act on that ergosterol. It's that lipid or cholesterol layer in the cell membrane. It's going to break that down and prevent it from forming. So that way, the fungal cells will then kind of be leaky and leak their contents into the bloodstream or into where the fungal infection is if it's superficial. So for both, we can give them PO or IV. We want to give these with food, milk, or fluids to help prevent GI upset. Both are fairly well tolerated. The big thing about fluconazole is you're at risk for Stevens-Johnson syndrome in our immunosuppressed patients. So if we're using fluconazole in a patient who has HIV, again, we're going to talk about those patients at the end of the lecture today. We want to be really careful that we're doing good skin checks and alerting the patient to what Stevens-Johnson syndrome could look like. For ketoconazole, aside from liver toxicity and menstrual irregularities, it can cause gynecomastia, which is the development or enlargement of breast tissue, and particularly in male or male identifying patients. And then it can also cause decreased testosterone. A couple of things specifically about these two drugs is that patients who are receiving fentanyl, so maybe pain relief or topically, if they have patches to provide sustained pain relief, or methadone, it will prolong the effects of those drugs. So those are pain medications that you would see respiratory depression. You might see depression of level of consciousness. You might see patients become more bradycardic or hypotensive with the administration of those drugs. And fluconazole and ketoconazole can amplify those depressive effects. And then it does interact with warfarin. So again, protozoa are single-celled organisms. So they live in water or soil. They can also live in animal hosts, and they're often found in areas where sanitation is challenging. So people may come in contact with contaminated water or soil when they're doing their hygiene practices, or they're not able to do hygiene because of contaminated water. And so protozoa you may have heard of. Some when we adopted our puppy had Giardia. And so we were at risk for transmission when we were picking up her stool after going for a walk, that we could transmit it to ourselves. So Giardia is a protozoa that attacks the intestines. It can cause fairly severe diarrhea. Malaria, which is going to be our kind of focus for this part of the discussion, which attacks red blood cells. Through IgN, you might be familiar with toxoplasmosis, which can cause fatal encephalitis. And then trichomoniasis is another protozoa. It's a sexually transmitted infection. So malaria is the second most common fatal infectious disease in the world. It affects about 300 to 500 million people annually, and it's transmitted through female mosquitoes. So it settles in the liver, multiplies for about 2 to 3 days. Oh, for goodness sakes. It multiplies for 2 to 3 weeks. And as it's multiplying, those new protozoa, remember they're single-celled organisms, they will actually attach themselves to red blood cells as they're replicating. And then they can travel throughout the body and they can also remain latent in the liver. I'm going to stop sharing here just for a second so that way I can share a video with you. Take a Zoom sharing here.
Malaria is transmitted among humans through the bite of an infected female Anopheles mosquito. The process starts when an infected insect lands on its victim and pierces the skin with her proboscis, a long straw-like extension with a pointed end, so she can obtain a blood meal from the host. As she feeds, Plasmodium sporozoites, contracted from other humans, and in rare cases animals, are transferred from her body directly into the bloodstream of the victim.
And I do want to show you part 2.
At Harbor Freight, we design and test our own tools and sell them directly to you. No middle.
People with malaria often experience fever, chills, and flu-like symptoms. Left untreated, they may develop severe complications and die. The sporozoites travel through the blood vessels and migrate to the liver. Once at the liver, the sporozoites invade the liver cells, where they grow and reproduce into merozoites. At this stage, no symptoms are present, and the parasite can remain dormant for months or several years. The multiplying merozoites then rupture the liver cells and invade the bloodstream. Traveling through the blood vessels, the merozoites infect new red blood cells and initiate a series of multiplication cycles, producing new infective merozoites. These blood-stage parasites cause the symptoms of malaria. The parasites grow and multiply inside the red blood cells until they burst, releasing daughter merozoites that continue the cycle by invading other red blood cells.
Great, so I'm going to stop our share here. So that way I can return us to our presentation. All right, so now that you can see how it progresses throughout the body, we're going to take a look at how common it is. And so here, we can actually see the spread of malaria, hopefully, if this will work. And so this website, which is ourworldanddata.org, gives you a great way to actually track the source. So this is the part that I was looking for so that you can actually see new cases of malaria and where those new cases are centered. And so while you may not see cases here in the United States, certainly as people continue to travel, particularly as travel restrictions and related to COVID continue to be scaled back or to end, I'm sure we'll see a continuation of the transmission of malaria throughout the world. And so, whoop, 1 second, please. There we go. So the biggest treatment strategy for malaria is actually prevention. So we give an anti-malarial for 1 week prior to travel, during travel, and then 1 week afterwards. So the most common treatment for that is chloroquine. Unfortunately, because of folks not adhering to the treatment strategy, or because, as all things do, we see evolution and change. There's actually chloroquine resistant malaria now. So using chloroquine as prophylaxis may not necessarily be helpful depending on where you're traveling to. And so our goal is to try to prevent someone from being infected if they know if they're going to be traveling to a known region. So for example, I went to Cambodia last summer, and so we actually took anti-malarials when we were going to be in areas where there was a high risk to anyone who was traveling to develop malaria. Now, unfortunately, prophylaxis, whether with chloroquine or other medications, often can cause nausea, vomiting, diarrhea. It can cause photophobia. So if you took a look at where the incidence of malaria is, unfortunately, it's in a lot of areas where there is a lot of sun exposure. It can also cause irreversible retinal damage. And so it's one of taking that into account when we're talking to patients who might be traveling. What are their risks for actually developing or contracting malaria? And what are the risks for them taking a prophylactic medication? So doing a really thorough assessment. We want to do early intervention if possible. So you saw in the video that once the Merozoites infect red blood cells, that they're then able to travel throughout the body and continue that replication cycle. So our goal is to try and get treatment early to eliminate those Merozoites from the RBCs before the red blood cells burst. And then we can use drugs like promaquine to eliminate those dormant forms that were mentioned in the video, where it can last for weeks, months, or even years in the liver. So we want to try and interrupt that dormancy, and to do that, we need to penetrate the protective coat that the protozoa can actually build around them. And so some of the challenges to treating malaria can be that the merozoites can actually travel to infect distant organs, and they can change form. And again, they also form those cysts that protect them from pharmacotherapy agents. And so that makes it very, very challenging because of the complicated lifestyle, not only of malaria, but a lot of these protozoal parasites. And so often we find that antibiotics and antivirals are really ineffective against treating protozoa. And so this is a list of common protozoa. All right, let me just resume sharing here for a moment. Okay, so these are other common types of protozoa that can cause illness or injury. And so some are often through fecal contaminated drinking water, but you may find toxoplasmosis is actually transmitted through cat feces. There are others such as trichomoniasis, again, that is transmitted through sexual intercourse. We've got tryptomoniasis, which is transmitted through an insect. And then some areas of the world may consider these illnesses endemic at this point, which can contribute to the mortality of children or other immunocompromised patients. So just being aware that these are also out there, and that depending on where you practice or where you travel to, that you may see these patients. So our prototype drug for this class is going to be metronidazole. So it acts on the cell DNA of the protozoa and actually breaks the structure of that DNA. So metronidazole is available by mouth. It's available extended release by mouth. It can be given IV or topical. And again, it's also usually well tolerated. You may see nausea, vomiting, diarrhea, which, if you remember from our antibiotic lecture, is unfortunately not all that uncommon. You may also see patients complaining of dizziness or a headache. And then some patients do experience a metallic taste in their mouth, and it may or may not contribute to anorexia as well. For these patients, again, warfarin is going to be an issue. You'll see that throughout the presentation when you're watching this. And these patients, you also want to have them avoid alcohol because it does cause a specific reaction with metronidazole. And we're going to monitor their CBC just to make sure that the patient's not developing a worsening white blood count or having issues with their red blood cells. Again, many of these protozoans may attack through the red blood cells. So next we're going to talk about helminths. So that's our parasitic worm. And so the life cycle of a parasitic worm, it either enters through the GI tract, so it might be a fecal oral contamination, or it might be through skin or through tissue. So for example, either at a gym or at a shared workout facility, you may have patients pick up a parasite like roundworm or pinworm. It may also just be transmitted through walking on the ground barefoot. And what happens is the parasite attaches to the human, it then matures, reproduces, and the bigger problem is that it can travel throughout the patient's body. And so our goal for treating these is to prevent them from really maturing and reproducing. So many of the helminths do attach to the intestine, but the bigger problem is if they move on from the intestine into the skeletal muscle or the liver, they can form those cysts, very similar to the protozoa, like malaria. And the treatment then becomes more challenging because we've also got to penetrate the cyst that the helminth has formed around it. And so treatment generally focuses on killing the parasite in the intestines and systemically, and trying to catch it as early as possible. So there's a couple of common helminths that you may see in your practice. Roundworm usually affects children in the US from about ages 3 and 8, picking it up from contaminated soil or poor hand hygiene. So there's very little resistance. So compared to antibiotics, that's been really something that hasn't been as common with parasites. And we're going to use mebendazole for 3 days for roundworm. And then pinworm is the most common overall in the United States, and it's 1 dose of mebendazole initially, and then retreatment again in 2 weeks. Again, trying to make sure that we're catching that life cycle of the parasite. So did we eliminate them with the first round of treatment and then 2 weeks, because that's about the reproduction and maturation time. So trying to make sure that we catch that, any that may have been in the process of maturing. So not all parasites or helminths require treatment. Some may die without reinfecting the host, but infestation is when we really want to make sure that we're making sure we get treatment for the patients. So our goal for anti-helminthic or anti-parasite therapy, things that we're worried about, physical blockage of the intestine. So particularly for roundworm, that it doesn't get in and create such a large number of worms that they block the intestine. And because they're intestinally focused, we worry about malabsorption. So the patient is eating and continuing to take nutrients, but they're not able to absorb those nutrients from their food because the intestine is actually blocked, or the walls are covered in parasite. And so the food moves through the digestive process without absorbing the nutrients. This also places the patient at risk for secondary bacterial infection because the body's already mounting an immune response, and it allows for other bacterial infections. And of course, the patient may feel severely fatigued if they are not able to absorb nutrients. And so our goal for antiparasitic medications is to kill any local or systemic parasites, and we want to avoid, or excuse me, we want to use narrow spectrum antiparasitic medications. So that way we're trying to avoid adverse effects for the patients. Remember, it's not as much for this that we're worried about resistance. We're more worried about if we use something broad, that the patient's going to experience the effects of a broad spectrum treatment. So I mentioned mebendazole. It actually decreases the ability of the parasites to use glucose. So glucose that's eaten by the client isn't able to be utilized by the parasites to grow, mature, and reproduce. Again, usually well tolerated, mostly GI effects if the patient's going to complain of any GI effects. And the administration is PO with a fatty meal will actually help increase absorption of the medication. So we're going to move on to viruses. And I put on here a couple of different examples of viruses. So the first one you'll see on your screen is HIV, which is what we're going to spend the bulk of our time talking about viruses. We talk about them and the treatment for HIV. You can also see bacteriophages. Those are viruses that attack and go through bacterial. You can see the flu. We're going to spend a few moments talking about flu at the end of today. We've got adenoviruses. We've got kind of a conical virus, the tobacco mosaic virus, and then Ebola, which was one of the first to be studied as far as retroviruses go. And that's also the type of virus that HIV is. So one of the things that makes viruses different than any of the other issues that we've talked about so far this semester, so even things like bacteria, which were in the antibiotic lecture, but also protozoa and fungi, and is that viruses are not alive. So they use host enzymes and cell structures to replicate. So they're honestly very sophisticated parasites, but again, they're not alive. They either are RNA or DNA based, and there's only a few dozen genes that are surrounded by a capsid, which is a protein, and some may actually have a lipid envelope on the outside. And so that lipid envelope often contains proteins that allow them to latch onto cells so that they can use the cells to reproduce themselves. So sometimes the viruses are very specific about what cells they can use to reproduce. So when we talk about HIV, it really can only use T cells in the immune system to reproduce. But unfortunately, viruses, because they're so, the DNA and the RNA have so few genes, they're also really able to mutate, which makes treatment more challenging and even diagnosis more challenging. So a friendly reminder that not all viruses require treatment. So common virus that doesn't require treatment is rhinovirus. So the virus that's responsible for the common cold. So a really important patient education takeaway is if your patient has the common cold, prescribing an antibiotic or even an antiviral is not going to be helpful in their therapy and can increase the likelihood of resistance. So often the treatment, or excuse me, the decision to treat is based on sequelae, which means the after effects, or the mortality risk for the patient. So making sure that we're doing, again, that really thorough past medical history. What's going on with your patient? Do they have other comorbidities that are going to place them at risk for injury or illness down the line if they do get a virus? So our treatment goals for viral illnesses is they fall into kind of three buckets. The first treatment goal is prevention. So if any of you can remember back to 2020, we talked about prevention as being one of our key goals when we talked about COVID. When we talk about flu season, we talk about coughing into and sneezing into your hand. We talk about really good hand washing. People who are ill should not go out in public. Educating the patient is So aside from primary prevention, our other goal is going to be antivirals and supportive care. So taking care of the patient once they do get ill to try and support their immune system in recovery, and then boost their immune response. So immunostimulants allow the body to keep the virus latent, which in turn helps keep the patient symptom free. So I do want to talk a little bit about HIV. So these are 2021 statistics. So I have not gotten the 2023 statistics from the WHO yet, but about 38.4 million people live with HIV, and about 1.2 million acquired the virus in 2021. Unfortunately, about 650,000 people died that year, so 2021. So between 2000 and 2021, new HIV infections fell by 49%, and HIV-related deaths fell by 61%. And one of the reasons that that happened, not only was there a focus on primary prevention, but we also really saw the rise of antiretroviral therapy. And so that really has helped save lives where it's available. And so taking a look at the demographics here, some of the demographics that you might find interesting are that in the Eastern Mediterranean area, you can see where that's pointed out, but only 27% of people who are HIV positive are on treatment. And only 41%, it's estimated only 41% of people who are infected actually know their HIV status. And so thinking about how culture might play into that. In Southeast Asia, 74% know their status and 63% are on treatment. So taking a look at how different cultures approach discussions about sex, discussions about sexually transmitted infections, discussions about reproductive practices can significantly influence both the treatment and diagnosis of HIV and AIDS. And so manifestations and opportunistic infections. So HIV can remain latent and asymptomatic for years. So a patient may not even know that they have HIV. They may know that they've got, at some point they developed vague overall symptoms. They may have fevers intermittently or a headache or a rash. And so the movement or progression of HIV to AIDS is gradual over time, and it's going to have to do with those T lymphocyte cells. So when we talk about the process of antiretroviral therapy, we're going to review how the virus replicates, because as the virus replicates, we can interrupt that process with different classes of medications. Now, one of the problems with having a patient who has HIV or AIDS for the patient is that there are opportunistic infections. So things like pneumonia or salmonella, or again, candidiasis and toxoplasmosis that we talked about earlier, Kaposi's sarcoma, lymphomas, herpes simplex viruses. These are all other infections that the patient can develop because they can't defend themselves. Their immune system, their T cells, are being destroyed during virus replication. And so even if the patient is healthy and might be able to fight off that infection, if your patient has HIV, then they may even have more severe symptoms than a healthy patient would. And so HIV stands for human immunodeficiency virus, where AIDS is acquired immune deficiency syndrome. So the virus is actually what the infective agent is. The syndrome, once a patient transitions from HIV to AIDS, is the fact that the body is now overwhelmed by viral reproduction. So we're seeing a syndrome more than just the virus itself. So because HIV uses T4 helper cells, the immune response loses its ability to function as those T4 helper cells are killed off by HIV. So the reason the life cycle is going to be kind of the focus for the next couple of slides is because in order to understand how the medications work, we need to understand how HIV replicates. And so again, viruses aren't alive. So life cycle is a bit of a misnomer, but it was the best way I could kind of explain what's happening. So transmission occurs either blood or bodily fluid that's infected with HIV is transmitted from a person to a person. That virus attaches to a CD4 receptor site. So we're going to talk about fusion inhibitors. So that's a place where fusion between HIV and the T4 cell occurs. Once that fusion occurs, RNA is able to enter the host cell being that T4 helper cell, and it emerges from the viral protective coat. RNA is then converted to DNA using reverse transcriptase. So we're seeing now there's several areas where we can interrupt the replication of HIV. We can prevent the virus from attaching to a T4 cell. We can prevent the RNA from entering the host. We can prevent that reverse transcription from occurring. Once that reverse transcriptase converts the RNA to the DNA, HIV's DNA will actually move into the nucleus and it will integrate itself into the host DNA. And so we can actually talk about integrase inhibitors. And then once it's integrated into the host's DNA, that's where replication occurs. So mRNA is formed from viral DNA, and that allows the cell to now also make viral proteins. And those viral proteins can assemble and bud off and leave the T4 cell. And so over time, as this continues to occur, it leads to the eventual destruction of those T4 cells that recruit an immune response. And that's once the patient develops AIDS, allows those opportunistic infections to really injure and potentially kill the patient. And so in case you're not familiar with the transmission of HIV, it happens either during sexual contact, broken skin contact, mucous membrane contact, needle sticks. It can occur during birth, and it can occur during breastfeeding. And so when we're talking about immune system function, we're actually going to be talking about CD4 counts. That's those receptor sites on a T cell. So the patient has these receptor sites that we're actually able to count, and we can see if our antiretroviral therapies are effective. How is my patient's CD4 count? Is it stable? So the patient's not getting sicker. Is it improving? We're actually able to prevent viral replication, and the patient is able to produce more healthy CD4 receptor sites and more healthy T lymphocyte cells. And so the patient's actually improving on antiretroviral therapy. And so I was here for a second so that I can pull up the video since it's not pulling up here.
When HIV first enters the human bloodstream,
what are you doing? Juggling everything I need to run my business as a creator.
I use Squarespace for my website, MailChimp for my emails, PayPal for my payments, Google for my analytics. Plus, I have to make and edit all my content. What does it look like I'm doing? It looks like you might need some help. You got a better way? Yeah. When HIV first enters the human bloodstream, the virus circulates throughout the body. The protective surface of HIV is studded with particular proteins called GP120, and inside is a capsid that contains the viral RNA.
Every year, the state of New Hampshire puts more tax burden on our towns, and it's hurting the people of Goffstown. I'm Judy Johnson, and in the State House, I'll push for responsible spending and a fair tax system for everyone.
Sorry about that.
When HIV first enters the human bloodstream, the virus circulates throughout the body. The protective surface of HIV is studded with particular proteins called GP120, and inside is a capsid that contains the viral RNA and viral enzymes. Initially, the GP120 protein on the virus is only able to bind to a cell surface protein on the macrophage called the CD4 receptor. A second receptor protein, CCR5, must also be present on the macrophage for the virus to enter the cell by endocytosis. Viral RNA and enzymes are released into the cell's cytoplasm. Reverse transcriptase uses the viral RNA to synthesize first a strand of viral DNA and then the complementary DNA strand. The viral DNA then moves to the nucleus of the cell, where it integrates into the host cell's DNA. Transcription of the DNA within the nucleus now results in the production of viral RNA. This viral RNA can serve as the genome for new viruses and can be used as messenger RNA to produce viral proteins during translation by the ribosomes. Complete viruses are assembled and released from the cell via exocytosis, which causes little harm to the macrophage. HIV cycles through macrophages over a period of years and continues to multiply while doing little apparent damage to the body. Eventually, the gene that codes for the GP120 protein is altered by mutation. The altered GP120 protein changes its co-receptor allegiance and now binds to a different co-receptor, CXCR4, which is found on the surface of CD4 plus T cells. The same processes occur within the T cells, resulting in new virus particles. However, as these new viruses leave the T cell, they rupture the plasma membrane, which kills the cell. As these newly released viruses invade and destroy other T cells, the body's immune response is weakened, and this leads directly to the onset of AIDS.
So now that we've seen how HIV progresses into AIDS, this illustration is directly from your Adams textbook, and it gives you the entry points for antiretroviral therapy. So our goal is to either prevent it from entering a cell, prevent reverse transcriptase from changing the viral RNA to viral DNA, prevent the integration of viral DNA to the host DNA, or to prevent those proteins from assembling and becoming new viruses. And so those are kind of the 4 stages of where we're going to see our antiretroviral therapy for HIV. So the goals of antiretroviral therapy are to reduce virions, so reduce the virus in the body, delay symptoms and prevent the progression of the patient from having HIV to developing AIDS, and to prevent the transmission of HIV from person to person. And so the way we're evaluating our progress and the efficacy of our therapy is checking the patient's labs. So an absolute CD4 T cell count that predicts the likelihood of opportunistic infection based on immune system function. And we can actually run a test for HIV RNA circulating in the patient's plasma. That's called viral load. The virus can remain latent in areas like lymph nodes, but a viral load gives us a relative indication of how the virus is responding to treatment. So where we're interrupting the viral replication process, is it effective in preventing new viruses from circulating in the bloodstream? And so theoretically, this should be simple, right? We give the patient a cocktail of medications that interrupts this cells and virus reproduction cycle. But the problem is we've got very expensive drugs, and this is a multi-drug regimen for the rest of the patient's life. Treatment always requires 2 drugs and may require even more. And it requires the patient to adhere to that treatment regimen very carefully. HIV is able to mutate easily on its own, and having a patient who isn't able to adhere to the treatment regimen makes it even more challenging and allows for even more mutation to occur. The medications also have to be taken on a very strict schedule. And so things like having a regular schedule, having access to a clock, and understanding how to tell time, those are things that are really important for our patients and might be barriers for them to be successful. As we add more and more medications to the patient's antiretroviral therapy, the number and severity of the adverse effects continues to mount. So what might start as simple vomiting and anorexia and abdominal pain can progress to liver toxicity or hepatotoxicity. It can progress to renal toxicity and renal failure. Some of the medications can cause cardiac damage and eventually lead to myocardial infarction or heart attack. And so the third barrier is that HIV mutation. So the patient may be on a particular treatment regimen, and even with adherence, they may find that they are starting to develop more and more symptoms, and their viral count is climbing because HIV that they have has mutated and is no longer responsive to therapy. So we're going to talk about a couple of different therapies, and I want you to kind of keep referring back to this slide to see where we are in the viral replication process. So the first 2 therapies we're going to talk about are reverse transcriptase inhibitors. So that's preventing the RNA from becoming DNA. So the virus has already entered the patient's T4, but now we're not going to allow it to make its own DNA. And so we've got nucleoside reverse transcriptase inhibitors, or NRTIs. The most common one in our drug that we'd really like you to focus on is zidovudine. You may know it as AZT. If you've ever heard the musical Rent, they actually talk about AZT. And so there are 2 other that are on the market, but they all kind of have the same short-term effects, which is nausea, vomiting, diarrhea, headache, and fatigue. So kind of vague symptoms. The problem is that long-term therapy. So it can actually disrupt mitochondrial function. It can cause destruction and change in internal organs. It can cause blood disorder. It can cause lipodystrophy. So the patient will actually lose subcutaneous fat in their face, their arms, and their legs. And they'll actually see fatty deposits in the abdomen, breasts, and at the base of their neck. And those areas will start to develop those kind of excessive fats. So the fat in the body will actually redistribute itself. And then the other reverse transcriptase inhibitor is non-nucleoside reverse transcriptase inhibitors. And so unfortunately, those actually have more severe short-term effects. And they should be taken at night on an empty stomach. They interact with statin medication. So if your patient has a liver disorder, we already are worried about them if they take a statin. And this, because it's processed in the liver, is going to cause additional problems. It interacts with methadone and sertraline, as well as calcium channel blockers, which are some of our cardiac medications. And so Aferovens is the prototype drug for NNRTIs. Our next drug class we're going to talk about, and these are the 2 most common that you're going to see as part of the cocktail. And so our next drug that we're going to talk about, or drug class we're going to talk about, is also part of a common drug cocktail, and that's a protease inhibitor. So now the viral DNA has become RNA, it's integrated into the host cell's DNA, and it's been replicated. But we're going to interrupt the manufacturing of new viral particles. So we're going to go all the way to the end here of our replication cycle. And we're going to interrupt the making and the combining of these viral proteins to allow HIV to spread. And so protease inhibitors, they've been essential in HIV therapy since 1995, so they're not new on the market. And they are mostly responsible for lowering the HIV RNA levels in the bloodstream. They can actually get those levels down to almost undetectable. The nice part about these is they're very few overall adverse effects. And there has been a lot of work with these to make sure that they can try and develop new combination therapies that would allow for less frequent dosing, because these need to be taken multiple times a day. And so they're trying to enhance the existing drugs, both because of mutation, but also to allow them to be more effective for longer. Now we're going to talk about fusion inhibitors. And so this is preventing the virus that's circulating in the bloodstream from fusing with a host cell. So it's very effective for those with highly resistant strains. So this is not our first line medication, mostly because it's very expensive. It's twice a day sub-Q injections, and it needs to be used with other therapies in order to be most effective. There are some fairly common reactions. So, of course, there would be site pain from where the injection occurs. The patient can also have erythema or abscesses develop. Remember, these patients are at risk for not being able to fight off even a common bacterial infection of an injection site. But it's utilized for treatment experienced patients, patients who have had HIV for a long time and have tried multiple therapies and unfortunately have continued to develop resistance. And it is effective in actually preventing that fusion. And the drug prototype for this is enfervatide. The other part of the antiretroviral therapy is integrase inhibitors. So dolutegravir. So that actually prevents viral DNA from joining with host DNA. So if we go back to this part of the cycle, here we're going to prevent the viral DNA from being integrated into the host DNA. So again, this is not a first line medication. It's also expensive. It's also part of a combination therapy, and it's good for patients with a lot of resistance to other drug classes. Again, those are called treatment experienced patients. It can be administered PO, which makes it preferable to our fusion inhibitors. But unfortunately, some of the adverse effects are GI symptoms, fatigue, headache, and it can cause neural tube deficits. So if your patient's planning to become pregnant or is pregnant, this is not an option that would be considered safe as for fetal development. And so we've talked about ART, antiretroviral therapy. And so what we can see is highly active antiretroviral therapy. And so this is the combination of multiple antiretrovirals working together to reduce HIV RNA, so that viral load, to the lowest possible level. So we use multiple drug classes, and that also helps decrease resistance because we're attacking the virus on multiple fronts. And so the initial combination is often two NRTIs, those nucleoside reverse transcriptase inhibitors, one NNRTI, or non-nucleoside reverse transcriptase inhibitor, or one enhanced protease inhibitor, or one integrase inhibitor. So we're almost always going to see two NRTIs, and then we'll have one of the other types of medications. So one NNRTI or one protease inhibitor or one integrase inhibitor. And again, we're not prescribers, so we wouldn't expect you to choose specific drugs, but be aware that highly active antiretroviral therapy is where HIV therapies are heading, because we're able to help attack the virus on multiple fronts, decreasing the likelihood of that mutation. So there's a couple other viruses we wanted to touch on. And so one is herpes simplex virus. So there are several different types that humans are susceptible to. So herpes simplex virus 1, it infects the eyes, the mouth, and the lips. It also can cause some genital infections, but HSV2 is much more common for genital infections. We have CMV, which is cytomegalovirus. That is more common in immunocompromised patients. VSV is varicella zoster. So that's the virus that causes chickenpox and shingles later on. EBV is Epstein-Barr virus. So you may be more aware of it as mononucleosis, and it can also cause Burkitt's lymphoma. And then herpes type 6 causes roseola in children, and it can cause hepatitis or encephalitis in immunosuppressed patients. Remember, our immunosuppressed patients may react to viruses differently because they don't have the ability to fight off those infections. And so one of the big problems with herpes simplex viruses is that they can stay latent in nerve cells in the ganglia part of nerves for years. So that's why there's a lot of discussion about, if you have chickenpox as a virus, what's your risk for shingles as an adult? And stressors, particularly physical stress or emotional stress or an immunocompromised state, can actually reactivate these herpes viruses and cause the patient to experience illness again. So herpes viruses are often transmitted through contact with blisters or lesions on the skin. Those lesions can also be on the genitals or on mucosal surfaces. And so just being aware that this is a way that the viruses are transmitted from person to person. One of the things we worry about is something called torch syndrome. So these are viruses that are transmitted from mother to baby. So here you can see the passing of the Olympic flame from torch to torch. And torch just is the acronym of the viruses, particularly herpes simplex viruses, though not only those, that can be passed on from mother to baby. So since you're taking IGN along with this course, most of you, it's good to be aware. Things like toxoplasmosis, cytomegalovirus, which again is a herpes simplex virus, other herpes simplex viruses, rubella, and then there are other infections that fall under this umbrella: HIV, syphilis, parvovirus B19, varicella, and Zika. So now that we've talked a little bit about herpes simplex viruses, the therapy for those, or the treatment for those, is to really kind of do two things. We want to relieve the patient's acute symptoms. We want the patient to not be ill. We also want to prevent future reoccurrences. So we want the patient to have an elimination of the viruses. So we're going to talk a little bit about acyclovir, because it treats herpes simplex viruses as well as varicella zoster viruses. So treatment can be oral or it can be topical. Often oral treatment is more effective. And then we actually can give acyclovir, which we're going to again talk about on the next slide, through IV therapy. So if your patient is immunocompromised or there is a concern that the patient has meningitis from one of these viruses, we can use IV acyclovir. Recurrent herpes lesions usually are mild and don't require treatment. Although if treatment is administered within 24 hours after symptoms appear, the overall episode might be shorter. So if a person has, for example, a herpes blister on their lip or a genital herpes blister, if we can initiate treatment within those first 24 hours, the duration and potential for transmission can be shorter. Patients who have frequent recurrence, maybe they have stressors that cause them to frequently have a recurrence of blisters. There's actually prophylactic antivirals that they can use, but we're not going to discuss those today. Just be aware that they exist. So acyclovir, it's used against herpes simplex viruses, specifically HSV1 and HSV2, though it is available at high doses for cytomegalovirus or varicella or chickenpox. And it prevents DNA synthesis. So you can give it PO, including interrupting the patient's sleep. We want to keep that serum level of antiviral at a stable level. If you're going to administer it topically, you're going to wear gloves as the healthcare provider. And then IV can cause very painful local inflammation. So for topical or PO, there's very few adverse effects that you really need to be aware of, particularly if you administer the PO with food. But we do worry about nephrotoxicity and neurotoxicity if it's going to be given IV to patients, which is why it really needs to be kind of reserved for patients who are immunocompromised or we're concerned about viral meningitis. As we approach flu season, remember, flu season is basically October to March, with the worst times being December to February. One of the most important things is going to be that vaccination, masks, making sure that patients are doing all they can to prevent themselves from getting ill. There are 3 common types of influenza: influenza A, B, and C. A is the most common. There are a few drugs on the market to help treat the flu. We're going to talk about oseltamivir in a minute. But they're expensive and they only produce modest results. It requires early intervention. So oseltamivir is only really good if it's given within the first 48 hours. After that, it can still be administered, but it's much less efficacious. So it's used to treat influenza A and B. It prevents the flu cells from leaving, the flu viruses from leaving cells where it's replicating. It can be given in liquid or capsules. The big thing about oseltamivir is it can cause Stevens-Johnson syndrome. Otherwise, the adverse effects are fairly typical for any sort of antibiotic or antiviral. We've got nausea, vomiting, diarrhea, dizziness. It can cause some irritability and agitation. Moving on from the flu, hepatitis. So hepatitis B is the only hepatitis for which the best treatment is vaccination. There are hepatitis A vaccines. It's usually the oral fecal route where patients get it, but hepatitis B, we're concerned about because it can progress to chronic hepatitis, cirrhosis, and potentially liver cancer down the road. And it's transmitted through blood and bodily fluids. So things like IV drug use, sex with an infected partner, male-male sexual relations, accidental exposure of healthcare workers, perinatal exposure, so during the birthing process, or even child to child. And so we can provide treatment for hepatitis B. We're going to talk a little bit on the next slide, but the big thing for our patients is to make sure that they really are getting that 3-step hepatitis vaccine. Hepatitis A, again, if you're going to be in an area where there is a risk for transmission, there is a vaccine for that, but usually it's transmitted through oral fecal route. And so prevention can really be good hygiene. Hepatitis C is also transmitted through blood and bodily fluids. And at this point, there is a cure available with direct acting antiviral drugs. They're not within the scope of today's class. I do want to talk a little bit about hepatitis B vaccination. Lifelong immunity is gained if the patient does get infected, but it does place them at that increased risk for long-term liver damage. So we want to really encourage vaccination. Treatment if the patient does end up developing or contracting, hepatitis B. We can use hepatitis B immunoglobulins. We can use PEG interferon or other antiretroviral therapy, but take a look at how long those therapies are. And again, the patient now is at risk for long-term complications. Thank you very much for your time and attention this evening, or whenever you do watch this.